So today is the last day. So after this, you all might miss this virtual training. And so I think before we start the section, I think people can say in the checkbox or by testing microphone, you can say something to other colleagues too. And also our facilitator, Piniwa, I think. As a reminder, I think probably the participant who joined have already finished the post-test evaluation form. As a reminder, if you have not finished the post-test evaluation questionnaire, please try to finish. I think in the checkbox, our colleagues have already shared link for post-test and also evaluation. Thank you. Piniwa, I want to ask you about how were you arranged for country presentation, by alphabet or by voluntary or by random, or what do you think?
Well, that's a good question for this morning. Well, it's still a top secret.
Oh, okay. You have a plan, so I'm happy to hear that. Okay.
Just
Thank
to make
you.
it more exciting, I can see Dr. Vino smile. So she may be ready to be the first. Well, we lady first, right? Well, I will tell you all when we touch base on 10 o'clock this morning.
Okay. Okay.
Thank you, Dr. Sin, to make it more exciting.
We have received now 8 presentation, but unfortunately our colleague from Iran have some difficulty because of COVID-19. He could not join, so we will have it will be like 7 presentation. One thing I want to clarify, Piniwa too, there are 2 presentations from Dr.Aneza and Rabia from Pakistan, so it will be like 2 country presentation. What do you think? We will have if we have time, should we? Should we allow? Because I'm sure that the setting, the scope might be different, so it will be interesting for the participant to listen.
Yes, agree with you, Dr. Sin. So you have 2 presentations from Pakistan. Yes, agree. Thank you for your observation and suggestions. I can see you smile from your eyes. Though you wear masks. That's good. You're smiling. Dr.Albert also smiling too, right? Yes, that's good. It means he's ready.
Yes, good morning. Good morning, everyone.
Good morning.
Yes, good. Good morning.
So more people are joining. I think we will have more participants. So if a new participant come, please say hello to everyone. And then we want to know about your voice quality, because today there will be country presentation. So you will have to present to the audience.
Good morning, Dr. Sin.
Good morning.
Okay, thank you.
Thank you. I think some of our colleagues and participants never open the video camera, so we cannot see. Maybe I was not aware probably, but they may open the camera. Today we will have a group photo again, right? At the end of the So now it's 10, and we still need more participants to join. So again, as a reminder, if you have not finished the post-test and evaluation, please try to finish. In the checkbox, the link have already shared. So today we will have so today agenda is very straightforward. Today we will have a country presentation. After one presentation, or maybe we might have a Q&A. We will not Q&A, maybe a question and comment. And Piniwa Pivan will be a key facilitator, and all the we also invited all our speakers, so they are now joining and they have already in the room. So after maybe another 4 minutes, we will start. So so before that, I have to announce one thing related to the questionnaire. In the question number 10 related to post-tag, there was some error. Actually, there are five response A, B, C, D, E, F. Actually, D was a correct answer. But at the beginning of the questionnaire, D was like a wrong answer. So the participant who responded at the beginning, it will show wrong answer for D, although they responded right answer, but now have already fixed it by our technical person. So our team lead PL requested to apologize that this is our error. So please focus on. So we were trying to recount the response answer and also the mark. So that is our error. So on behalf of the team, I apologize for inconvenience. But in the one you have not responded yet, and now you respond, the answer now is we have already corrected, so it would be a right response. So I think we nearly have all the participants. So the participant who joined, I think now is 10:05. I think it's time to start because we have a presentation today and we don't want to overshoot. So today is the last session of virtual training. Good morning to everyone. Sawadee krap. So today, I think this is the agenda is straightforward. The first is module 10, country presentation. We have already received 8 presentations. Unfortunately, one of our participants from Iran could not join because of the COVID situation. So we will have 7 presentations by our participant country. So today we have already invited all our speaker and facilitator. They will be here. They have already joined and they will ask the question to our participant presentation. So I would like to invite Piniwat to take the floor.
Thank you, Dr. Sin. Good morning from Thailand to everyone. For today. Well, today is the last day of these virtual trainings. We are on the same room of the virtual training, but stay away from each other. I don't know how far the farthest distance between us, but anyway, today it's more exciting for me to listen to you. I think today this will be a good, maybe the best session that we can hear from you, your experience. So let me try to relax. It's a kind of sharing story idea, and then we can listen for more perspective, for more opinion, advice, suggestion, or question that will help us learn from each other more and more, and to create the stigma and discrimination reduction in HIV related to HIV in your own country and in our region or in the global levels. So this will be a good opportunity. Today I have some kind of information to inform you first. Like Dr. Sin mentioned that we received 9 presentation from 8 countries, from 7 countries, but Iran colleagues cannot join. So the way that I will prioritize that, when Dr. Sin asked me earlier, is depend on my computers. So just inform you first. I'm sorry. Just inform you first to be prepared. The first country will be Cambodia, followed by Laos, and the third will be Thai. Then followed by the 4th will be Pakistan, from Rabia first. Then the 5th will be Pakistan from Dr.Aneza. And then 6th will be Sri Lanka, Dr.Vino. And then 7 will be Tanzania. And the last one will be Tanzania by Dr.Albert, sorry. You forget to announce your name. And then the last one will be Timor-Leste from Dr. Mark. So the way that we organize session, and then we have 8 resource person. 8 resource person to give you advice, ask you question, give you advice, suggestion or guideline for you. let me check first will be, I think we have Dr. Kai. Can you wave your hand, please? Just check. Okay, you hear my voice. Yeah, Dr. Kai is from Chiang Mai University. Miss Tananda? Yes, from Thailand CDC. And we have colleagues from UNAIDS. We invite 3 persons from UNAIDS. UNAIDS Thailand will be Dr. Pachala. Yes. And followed by Belis from regional office. I think she's on the screen, right? Yes, I see her, but I'm not sure if you can open, if you feel free to open your camera. It's okay, you just chat, you inform that you hear that. And another person is Famida from Pakistan, UNAIDS Pakistan.
And new one, I have not seen her yet, but
okay,
just see.
Okay, maybe later to check. Thank you. Next person, the 6th will be Miss Palichat from Division of AIDS in Thailand. Okay, she waved her hand ready. 7, Dr. Sunisa from Chulalongkorn University. Yes. Yeah, thank you. And then the 8th will be Mr. Third Chai from FHI 360. Yes, he's come with his mustache. So this 8th person will give you question, comments, and a guideline. So the way that I will organize, since we have like around 139 minutes, 35 minutes for presentation and comments, suggestions. So I will divide the presentation into 3 groups. Each group will have like 3 presentations. Then followed by, so the first will be followed by, start by Cambodia, Laos, and Thai. And then we will ask, request the comments from our commentator or resource persons. I will ask 2 persons to comment and 1 volunteer, I think, as this planned. So each presentation will use around 8 to 9 minutes, 9 minutes, let's say 9 minutes. We have 9 minutes only. I will warn you for the last 3 minutes and the last 1 minute. Please apology for interrupting you. I will say that, okay, 3 minutes left, 1 minute left, and you have to finish on that. We'll cut off the presentation after 9 minutes in order to, organize the time. And we'll allow around 20 minutes for question and comments or suggestion from a resource person. This will be for each round. If this is fine with you. Okay. Okay, there are 1 more presentation from Myanmar. Let's see. The last one will be on the last. Let's see if we have time. I'm so sorry for the other person that may have some ideas of thought, but we don't have time allowed to send to do the presentation or send us, or even you send later, maybe you need to be on the queue, right? Okay, so today's program will be at least 2 parts. We'll use this time 10 to 12, 13, 2 hours and 15 minutes for module 10, this presentation and comments and suggestion, and then 10 to 15 minutes for break. I will come back for the 30 minutes for the last session. Will be a closing ceremony around that. Let's see how we how we arrange our time. I will be more flexible. Okay, if you are ready, and let's see by time, if we have our commentators on board, we invite that. Okay, let's see, we'll start. If you don't have any kind of suggestion or change, allow me to follow this. Okay, so our organization, our control room will be a person in charge of sharing your slide. Some of you sent 2 files, so we'll open the first file first. But if you say that you need another file, let inform us. Okay, so are you ready? If you ready, give me your heart on your screen, please. Let's see. How can you no, okay, even your camera or the sticker. Yes, some send the sticker. Okay, let's see.
Sorry.
Yes.
Yes, I'm sorry because of my slide presentation is have something updated on it. So could I please share my own slide, or I need to send?
Okay, thank you. Goes for inform us. Okay, it sounds like he's not exciting anymore, so he's ready to present, right? So Gosa will be, sorry, may make mistake pronunciation, but Gosa will start first from Cambodia. So welcome, colleagues from Cambodia. You have 9 minutes, please. You can start share your slide, and when you start present, I will take a look at my clock.
Okay. Good morning, everyone. Do you see my slide?
Yes.
Yes.
Okay, thank you.
Okay.
Okay, so let me start with my presentation on my task. Okay, good morning, everyone, and good morning, organizer from Thailand, also resource person. This is a great opportunity for us from Cambodia to present our work plan to all of you to see and another thing together to do together. Okay, so let me start for the first slide. So I would like to show you the background and some problem related to HIV and SND in Cambodia. Actually, Cambodia has a success to respond to HIV prevalence. We decreased from 1.8% in 1998 to 0.6 in 2070. But also, however, we have remained high prevalent among key population like entertainment worker or sexual worker. It has 3.2 percent, and also men who have sex with men is 2.3%. For the transgender is it remains 5.9%, and also people who inject drug also remain high prevalent. It is 50.2%. According to the survey related to the according to a commitment of the Cambodia Ministry of Health and another partner, we success to in the target 1990 to increase the prevalence of HIV in Cambodia. Another survey according to the CPN Plus research reported in 2019 on the HIV stigma index. We see that 1,220 cases have stigma and discrimination on PLHIV as PLHIV. In that, we see that 5% is a man, and also 6% is a woman. Still have stigma among PLHIV. But we see that what is the main problem related to stigma is a self-stigma or internalized stigma. It still high. It's that that is 75% among men and 72% among women. Okay. Actually, Cambodia has also some policy to eliminate the stigma and discrimination that we conduct or develop the policy of advocacy or any regulation to general population, and also people who at risk with HIV that was coordinated or developed by Ministry of Health and Ministry of Education, Sport, Youth and Sport of Cambodia, and Ministry of Interior as well. Another thing is we see that our Cambodia has boosted enabling environment to help to support the MAP, like most every population like PLHIV or general population as well. Through the advocacy for gender-based related to law or policy as well. And also reduce the stigma and discrimination and empowering the village health support group to build their capacity to make them strong related to work on the stigma and discrimination in their community. Okay, this is the goal that we prepare for our activity. Our goal is we want to reduce the HIV related to stigma in healthcare facility among key population and PL-HIV as well. We have two objectives. The first one is to provide baseline stigma and discrimination situation among key population and PL-HIV. And the second one is to give evidence for, for Cambodia context on stigma and discrimination among key population and PL-HIV also. This is our method. So we have three main points. The first, the second, how and who. Actually, we prepare our activity about what is, we will conduct a survey for the stigma and discrimination on key population and PL-HIV. And also we will conduct a survey as well with the healthcare provider related to stigma and discrimination. And how this is survey will conduct through the we will use the S&D6QI questionnaire that you mentioned and presented us the previous time, and who will respond on this activity. In that, for the participant is we have a key population and PL-HIV. I'm sorry because I forgot to add some person who include in this.
3 minutes left.
Okay. So the second activity will provide training to the awareness on S&D reduction, and we will conduct a training and workshop. The fourth is provide training awareness to S&D about S&D reduction to PL-HIV and key population. We will the last this method is we will have a monitoring and evaluation as well. That we will prepare a S&D management team, program management team for that activity. For the expected outcome, the first one is we will to measure the prevalence of stigma and discrimination among key population and PL-HIV in health facility. The second is to identify the main factor related to the stigma and S&D among key population and PL-HIV as well. The third is we will building a capacity of healthcare provider, PL-HIV and key population on S&D. The fifth is we will enhance the try in health facility service and also the follow up the need of healthcare provider. This is the key activity that this is M&E that we will prepare. We will have a monitoring and evaluation. The key stakeholder related to this will be have S&D program management team. This is our SWOT analysis that I have no more time for you to show. Okay, this is a requirement on the technical support and resource. We have 5. The first is manpower, and the second is money, material, managerial information, and time as well. Okay, thank you for my presentation. If you have a comment, please give me to know. Okay, thank you, Dr. Niwan.
Thank you, Kosa. You have done a good job in time. Okay, you faster than we planned, like 30 seconds. It's good. For the resource person, you kindly note your comments or suggestions first, and then later on, after finish Thai, all 3 presentation, and then we'll let you to give comments. If it is okay with Cambodia friends. Okay, thank you for Cambodia friends. Can we give our big hand to them? Yay! Thank you.
Thank you. Thank you.
Okay. So the next will be colleague from Laos. So we'll share your slide from outside if this is okay with you.
Yes, okay. Please stay
outside. Okay.
Yes.
Again, you have 9 minutes. Okay, ready for you, please.
Yeah, good morning. Bisai represent for our country. Now we would like to present on the work plan on addressing HIV-related stigma and discrimination in healthcare setting in Laos. For the background or problem statement that I will present on that the Laos country is located in Southeast Asia and share border with 5 countries, as you know. And for the population proportion is around 7 million people. And the estimated PL HIV from AEM 2021 that around 15,000 people. And the number of the person that diagnosed with the HIV in 2020 is around 10,000. For the people, when we look at the prevalence among the people in 15 to 19 years old, that in the survey 2016 that we found that 0.7, and from the IBBS or integrated biological and behavioral surveillance from 2020 for the female sex worker, among female sex worker around 1%, and among MSN around 5%. For the total number of adults currently on ART, by the end of 2020, around 8,000 or 78%, and not received the ART yet, around 2,000. Yes, next. If you look at the fast track 1990, by the end of 2020, we found that the people that they have test and know their HIV status around 70%, and they have received the treatment or on ART around 61%. They have VL HIV testing for 81%, but the VL or viral load suppress only 70%. Yeah, this is the situation of you please next. Here is the routine monitoring of the S&D reduction in healthcare facility that comparative the trends of S&D for a common question. But I took from only like a 5-minute question. Yeah, like a fear of infection, like worried of getting HIV when drawing blood from PHIV. When you look at the trends that for the first round is around 36%, until the third round is going down for the minimum 20 to 22%, and it's growing up again in the fifth round, or in the fifth round for 26%. And avoid physical contact is growing up from the first round to the fifth round, from 11% to 18%. And for observed healthcare workers that providing poorer quality of care to PLHIV, that's yeah, it's good. Yeah, because it's going down from the first round to the fifth round. And we're double growth when providing care to the service of to a PLHIV that is growing up again. For the goal and objective, that to reduce the experience stigma and discrimination among people living with HIV and key population attending health care facility in 11 ART sites. The ART site that yeah. Okay, please next. For our method is we have like a 5 method or 5 activities. The first one is the like assessment on S&D in healthcare setting at 11 ART site that we will like have the routine survey on S&D by using the Google form or the online application. And second is like a training on S&D reduction for healthcare provider we will like applying for 3x4 packages that we have learned in Thailand, that we have learned in this training. So we will apply like a 3x4 package in this training. And the third one is the quality improvement project that related to S&D reduction in healthcare setting. And the fourth is like a development of the curriculum for medical and public health students. So we will like including the S&D lesson learned to the curriculum. And the fifth one is like use of social media, such as like Facebook. For our expected outcome is to increase the understanding of human rights and medical ethics in the context of HIV, and to reduce the negative attitude toward people living with HIV, and reduce stigmatizing behavior toward people living with HIV and key populations. Is our expected outcome.
3 minutes left.
Yes, for the monitoring and evaluation, there are 3 measurements which will be done, like S&D survey. The survey, this survey we have been done since 2016, and we will like conduct the survey again after 3 years. Until now, we haven't do the survey again yet. Maybe we will plan to do in the next year. And the routine S&D monitoring indicator is like to access and monitor, evaluate the S&D reaction intervention in healthcare setting. Like we will like use a questionnaire, the common question. And the data correction, we will like use Google Form, as I told you earlier. Yeah. And we planning for the next quarterly data collection around September 2021 with 11 ART site, and we will like expand to the POC site, point of care, yeah, to like a 2 site. And for the clinical outcome, we measure like an impact of S&D reduction intervention on health outcome, like a QI, early, receive early ART, lot to follow percentage of lot to follow up, and percentage of viral suppress that we will take regularly. Yeah, it's the same, right? The routine S&D indicator for monitoring like healthcare every month that I told you earlier. And we plan to incorporate the QI site coaching, including S&D with clinical monitoring and supervision activity. And also develop the S&D CQI activities in healthcare setting, adapt and discuss how to get the consumer
1 minute left.
Routine visit of the patient and ART. Yes, next. Yeah, here is the required technical assistance and support. Partnership will be like a UNS EPIC or CSO like a CS, PIDA, APA Plus, FSI. The government will be like a youth union, women union, and Department of Healthcare Rehabilitation or DHR that we will like integrate with Laos Quality Healthcare Policy, like a 5 good, 1 certification. And we will like working with the University of Health Science for the school curriculum. And we will need like a TA and fund trainer from Thailand for our training, and also Thai module or 2. Thank you.
Thank you. Wow, it's on time. I think we are exciting for the presentation too. Thank you. It's very fruitful. Lots of details. Thank you very much. You have a big hand from Ms. Pananda. Can we give a big hand to Lao friends, Lao colleagues, please? Thank you. Thank you. So the next one will be our friends, our colleague from Bangkok. Please. From DAS, Ms. Taksika will be a presenter.
Good morning, everyone.
Yes,
Speaker of Thailand today.
Time start.
Let me introduce myself. Okay, I will start. Let me introduce myself. My name is Taksika. Can you call me a coordinator for today? To show my slide. Okay, can you see here?
Yes.
Okay, my sound is clearly. Stop video. Good morning, everyone. First of all, I would like to thank you, the speaker and participant. This is the online training. This is a good point to share ideas and cooperate with another country. Present on this section show the way to travel on stigma and discrimination in the future.
Excuse me, can we stop the presentation for a moment? The noise from the background is very loud. Thank you.
I think she's in the working room with her colleague still working. So that's, well, let's see. Okay, how can she manage? Give her a time. So some still cannot work from home. They have the duty to work. Okay.
Sorry, I'm going out of the room.
Yes.
Okay.
So you can see it, who is the powerful person. So she have to left the room to another room. Let's see.
Thank you. Thank you.
Okay.
Look at the background and continue at the background, the HIV situation. Thailand have a national scale for SME reduction in healthcare facility. Since 2017, we piloted 3x4 package to reduce stigma and discrimination in 3 province, 6 hospitals. And next year, we also integrate with the CQI and begin to work the stigma reduction program and SRP. Until 2025, we have 71 province and 116 hospitals to join with us. What is the goal? We forgot to expanding 3x4 package to operation and nationwide coverage and quality. The quality of work we integrate with the CQI, DSC, HNA, and also SRP, CS, key population, and tuberculosis. Moreover, we try to implement to linkage with the community because we believe in people living HIV, they are the part of society. Okay, therefore we need to grouping the crisis response system, self-stigma, and 3x4 package. In the stigma discrimination package in one setting, we link work process in the community by we have equipment such as QI learning, SNDE learning, scholarship, and learning center to driving target of the nation is 90% of stigma and discrimination reduction of 0 number 3. And also we have a method can separate in 3 levels. Including new, basic, and advanced level. We put in different interventions. For example, we extend the 3x4 package in a new level, promoting to SND CQI and coaching to 110 hospitals for refreshing activities. And the last one is we put an intervention about the SRP, tuberculosis, key population of the advanced level. Next. Between output and outcome, the output we need 80% of hospital in each province. They come join to stigma and discrimination driven by a 3x4 package, include SNG workshop, QI, and code of practice, SND learning and self-stigma reduction program. To challenge the outcome and people living HIV fail in healthcare system, more than 80%. They can spread the virus and promoting SND CQI in hospital as well. And how to monitoring and evaluation by the quantitative process. Composite SND survey to compare to changing in SND situation, hospital and healthcare worker train about learning costs. And the last is qualitative such as the academic conference forum and multi-country meeting, QI network, and the last one is also lesson learned in hospital. And 3 things that we need to support. The first one is special and technical support to help about the knowledge and principle. The second, the coaching team to cover the nationwide, regional, and province, and the last one, technical but to support about the online workshop. Thank you. Yes, thank you. is also done.
Yes, thank you. She's even though she's from Thailand, but she's like from Japan with Shinkansen speed, high speed. But anyway, thank you very much for Thailand's colleague from Bangkok, and apologies for the interrupt voice. Anyway, so right now we finished 3 presentations and with 5 minutes in stock, so we will allow like 20 minutes, just only 20 minutes as planned to for comments and questions for Cambodia, Laos, and Thai. But before giving comments, please give a big hand to Ms. Taksika, please. Thank you.
Thank you. Thank you.
Thank you. So I don't know how to start. How can we start with a resource person? But let me see. Can we start with whom will be first? Let me see who is on the screen right now. I see. Okay. Can we start?
I can start first, Niwat, if help.
Okay. Okay. Yes, go ahead. I think Kun Pachara's voice, right? Yes. Okay.
Okay. By the way, thank you very much for 3 country presentation. It's very comprehensive, and also I found that it's very focused as well. Having said that, because these 3 countries have been, passed on the process and working together at the Asia, Southeast Asia, with become very good access for moving forward. I just work very short on each country now, because many resource persons to contribute. Very congratulate for Cambodia. I think look like that you already passed the 10-10-10 target on the 2025 based on the stigma index. You already below 10% people experience on discrimination. That congratulations, and I really appreciate that you focus to the point on the target on PLHV who are key in the key population. That very right target. Just on the method, really, you mentioned that going to have the training on less awareness, but would like to remind that, as we discussed earlier, that key driver in healthcare setting is based on the theory and based on the around the world literature. We're talking of awareness is one of key driver, but we have to adapt on the fear of infection, attitude toward the PLHCV and key population, and also address on policy and environment. If you're able to incorporate, will be very nice. And I really like the idea to go together with the care provider and key population complement to one another. In the same time, we'll be excited to see what the result of participatory training from Cambodia. From Laos, only thing that the key question will be, it's very nice if you can incorporate the community engagement on the plan that going to pursue in the future. But having said that, in very interesting result from the routine S&D common question, because it's go different direction on the observed stigma, and the key driver doesn't support to one another. If you can look at the detail why that's the case, will be very nice. And for Thailand, I believe that, only for the key point for Thailand will be how we really make the correlate at the scale on exposed to the packet of service. In the same time, we also move forward on the comprehensive packet adding the cell stigma in and other things that a little bit on things moving on the key point for Thailand to move forward. That's my comment. Thank you very much, Niwat.
Okay, thank you very much, Kun Pachara. And then for the next, I would like to invite, since there's some of them mentioned about self-stigma reduction program too. So I would like to invite if Dr. Sunisa has a kind of advice or comments on, I think remember that the Cambodia mentioned about this. Thank you, Dr. Sunisa.
Thank you, Piniwat. So nice presentation and nice plan that all of you put your effort to conduct and to work on that. So for me, I have just only 3 points to maybe just like a suggestion or remind to all of you to concern about your presentation or your plan. The one point that I found you present about the plan to just like you need to survey the situation. So for me, I think that's very nice. And one thing from my experience that should be concerned about how to connect to your main population. How about your key person that can catch up for your good population that will help you to get the strength data from your survey. That one point. And the second point that I heard about your concern about the clinical outcome, and this one is from my experience too. My suggestion that you should look at indeed for the system that you should be set first to think about how to set the clinical outcome and how to set the system to collect that data. That is my view and my experience that I found from my study. And another one that I concerned about when you present about your plan, you look at for the level that you need to work, such as the system level. And the second one, you concerned about the individual level. And the last one, you present about the community level. So, and for me, my suggestion that in community level, it's so hard to think about the plan. And for me, maybe a suggestion for look up in deep to create your community connection plan and maybe set the guideline and set the key person to work with you, and that might be good start and good to check your plan again. Thank you.
Thank you, Dr. Sunisa. I think Kun Thananda raised her hand, right? It's okay.
Right.
Okay, thank you.
Invite me, but I like to talk.
We still have 10 minutes. 15 minutes.
Okay, I try to be short. First of all, I think all 3 countries are very nice presentations, and congratulations to all 3 countries. I think you have pretty advanced plan on S&D and really clear layout for your plans. I like to start with Cambodia. I think you have very clear background and plan and methodology to conduct your S&D program. Just key point that I think I was stuck by your data. I think you have pretty much good data, stigma index and cell stigma, which to be a bit surprised that you have I think pretty low stigma index toward PRHIV, while cell stigma are really high, both men and women. So I just think that for your country, you may consider to move this ahead in terms of focusing on the cell stigma, because you already reached, I think, the first and second 95 already. I think so. You probably can do something more focused. And your work plan, I think, is pretty clear. You lay out what, how, who, but I think you can add when in your table that when you're gonna conduct these activities. I think we can use Cambodia as kind of the milestone or example to develop for other countries. For Laos, I think it's very interesting to see the data that you routinely collect on those 5 questions. And some seems to be kind of higher when you keep measuring, which is that may lead to what intervention that Laos plan to implement to address those questions. But I think you already lay out good plan on that one. Just a couple points for Laos. I think you mentioned about integrating the S&D in the medical and public health curriculum, which is I think it's very nice thing and probably very good thing to do to make the background for the medical people and public health people on these issues. And I just think that Thailand also developing the e-learning curriculum, which I think it's the collaboration between UNAIDS and Division of AIDS and Thai University. And I guess that since we understand Thai and Lao language, we are pretty close and can understand each other easily. This may be helpful or useful for Laos as well. But I think after we finish the development, we probably can share on those things. The other points for Laos, I think from your data that show maybe the attitude or the worry, the anxiety about getting infection. That question I think we discussed a lot if that means a lot of things for the stigma behavior or discrimination behavior. But I think it's my general comments for other countries too. Maybe that inter-life feelings, worriedness, anxiety is not as necessary or as important as the way they behave to their clients. So I think the good practice, like the clear guidelines on the performance or behavior that providers should do professionally and not make the client feel discriminated. So that may be something we can do before changing the people attitude, which might take more time. For Thailand, I think it's very nice. Just a couple points for Thailand that for the expansion, I think Thailand has been in the expansion phase and more advanced package. I just think about probably Thailand should prioritize where we implement the program. I think Thailand has good data on the stigma surveillance. So we might use that as an indication for prioritize or intensify the S&D intervention by using the data to guide or the level of package to guide or probably just the disease burden of HIV or the poor retention kind of thing instead of expand the program throughout the country, which would take time to cover all for the whole country. So I think that's all for me at the moment. Thank you.
Thank you, Mr. Nanda. We have 5 minutes left for 2 hands that our resource person would like to say. So I would like to invite, you both share in 5 minutes. So I would like to invite Beles first and then followed by Kun Parishat.
Thank you very much.
Thank you.
Okay, great. So I think my colleagues have literally spoken about most of the things I wanted to raise, but what I wanted to really spotlight is the need to support civil society organizations, people living with HIV and key populations so that they can be able to provide a good quality data. It is important that they also understand what the interventions that are being proposed, how these interventions will help them so that they are able to provide this data. So while we are training healthcare providers, it is also important that even the key populations, people living with HIV, are trained on stigma and discrimination, on why this data is important and what this data will be used for. That will really improve the quality of the data that will be collected, and will also help in, the data could also be used in for advocacy purposes. And as we all know, civil society organizations and communities of people living with HIV and KPs can really help with the advocacy bit and policy and legal reform with the data that will be collected. So that's really what I wanted to point out to run across the 3 presentations. Thank you.
Thank you, Ms. Biris. So Kun Parishat, please. Okay, we still have time. Dr. Greenguy also on the queue too. Let's see. Okay, Kun Parishat.
Many comments. Okay, thank you, Kuniwat. Thanks for our presentation today. I'm sure that under state and time constraints, I'm sure that you work very hard to develop an action plan. Appreciate everyone so much. Since I'm not sure what size of hospital that you plan to implement, because this issue will affect the design of intervention, especially the training activity. So I have a point which Laos PDR or other the rest country consider for conducting training if you would imply the participatory training which you learn in Module 5. This training is designed for small hospital having not more than 150 or 300 staff. So and each time of training should not exceed 30 participants. So this training is fit for small hospital. And for a large hospital, if you implement in large hospital, you might decide it as a strategy to build understand with the core team or healthcare worker who will be as a change agent in your hospital, such as department head or supervisor, or maybe someone who have skill on training or who has an influence on other people in the hospital to help you to train other further. That it will help you to consider for design training for the last hospital. In this case, you might think of other activity to complement as well, or doing after the training finish, such as you might developing e-learning or for large scale of for have more to increase coverage of healthcare provider to understand S&D, or maybe apply our e-learning as Kun Kananda said, or other activity that you might do after the training, such as developing code of conduct, or maybe followed by the CQI process. When you file that the form of stigma in the hospital, this you get from the training. And apart this form of stigma, it will help you to do CQI to begin CQI process. Apart from you using the result of S&D survey in the hospital. And second, health worker often have a problem with time for participating in the long training. Most of them, based on our experience, most of them prefer half day or 1 day training. If your course design is more than 1 day course, I think the administration of your hospital will be required to support and allow work day off in order to not to be followed or to call for work after during the training. That is my experience to share with you if you would like to decide for training. Thank you.
Thank you. So we run out of time for comments and questions right now, but since I'm not sure, well, I will be maybe well organized for the next round. That I think that for the commentators or resource person, you can raise your hand and then I can pick you up first. But anyway, since Dr. Grengai also raised his hand before, and apologies for Kun Chai for maybe the next round. So I will allow Dr. Grengai to say something. Please, Dr. Grengai.
Thank you very much, Kuniwat. Just very briefly, thank you very much for the very informative presentation. I have very specific technical recommendation, one for Cambodia and one for Laos. For the Cambodia presentation, I observed from the presentation that you plan to conduct survey once a year, but you plan to train 2 times a year and also plan to evaluate the program 2 times a year. So my suggestion is that you can adjust the schedule of the survey to be 2 times a year also. So it can be synced with other activities and provide the feedback to your system. That's just my recommendation. For the Laos team, I think that you have benefit of having several rounds of results from the routine monitoring. And one observation that strike me is that the observed discrimination is increased. So as Dr. Pachara said, that it's the opportunity to explore more, maybe conduct some qualitative study and talk with the staff. Some explanation is that maybe because of the turnover rate of the staff, you may need to repeat the training again. So thank you very much.
Thank you very much. Okay, I'm so sorry, Mr. Thachai. Maybe next round I will invite you first. Then you can come back to visit these 3 countries too, right? Okay, for the next round, for resource person, if you would like to give comment or suggestion, maybe better raise your hand and then I can see that you are already there. Okay, thank you for the first round for 3 countries and all comments and suggestions from our resource person. So we'll move to the second round, the third presentation, the 3 presentation. The fourth one will be start with Pakistan from Mrs.Rabia first, and then followed by Dr.Aneza, and then finished by Sri Lanka, Dr.Vino. Okay, can we start with the presentation from Mrs.Rabia?
Yes, I'm here.
Thank you. Okay, just to inform all of you that the presenter will have 9 minutes per presentation, and I will inform you in the last 3 minutes and 1 minute. Okay.
Hello,
yes,
good
please.
morning. Hello, good morning. My work plan is on stigma and discrimination regarding HIV. I am from Rabia Shah, Pakistan. Next slide, please. For the study, background and problem statement, Pakistan is the first HIV/AIDS case was detected in 1987. The number has been increased regarding the annual report of Pakistan National AIDS Control Program, and ACP of Pakistan was considered a prevalence country, but now it's in the group of countries in transition phase, with the concentration among high-risk groups where the AIDS problem is increasing since several years. Here, I would like to share my experience when I have participated in data validation program of NACP, National AIDS Control Program, and we have worked in 2 major hospitals of Karachi, Pakistan, one of civil hospital and the other one is the Indus Hospital, Karachi, and the one from interior, that's Larkana and Chandka Medical Hospital. There we have validated the validation of the program, validated the data of HIV cases, and we have also done proper entry also being done in a specialized software of HIV patient. The statuses of that time. The patients, number of ever registered patients at that time, and I think we have done work in 2017 September. The number of ever registered patients of male 624, female 104, and transgenders were 12 only. New patients entered in that month, current month, 24 male, and there was no female, transgender also 0. At the end of the month in September 2017, male 648, 104 females, and transgenders 12. So at the end of the September 2017, the data completed data was total to registered patient was 764. I've mentioned here reporting month or year September 2017 and the center. This was the date of Indus Hospital, Karachi, Pakistan. Actually, the exact HIV cases could not be measured because people did not like to test only because of stigma and fear. And that's why stigma creates gap in accurate findings of HIV and HIV-related illnesses. However, the available information suggests a slower case detection and confirmation and any response services for the infected population. This may be resulting from the fact that the HIV cases cannot be calculated exactly because patients or HIV cases did not test actually. The next slide, please. Thank you. For this study, I have actually because as I'm working in research center, Pakistan, and my organization name is Pakistan Health Research Council, PHRC. It's associated with the main hospital. My organization, which is already a research organization, my goal will be after this e-learning session of HIV stigma and discrimination would be to prepare an action plan or an policy making to ensure that the HIV test should be mandatory in lab panels. Objective to meet the goal, making this goal, to meet the goal, there should be pilot scale study. So initially at first step, I think the work will be done in different wards per hospital where already I am working in a tertiary care hospital. Therefore, firstly, we select suppose a gynecological ward for getting samples or a study participants. So the objective of the study would be prevalence of HIV cases in pregnant women of a tertiary care hospital. For how, what, and who will be responsible? All the pregnant women of first, in this slide, I am sharing the methodology for that, what will be doing in this study. I shared methodology. All the pregnant women of first trimester who will visit hospitals or OPD of a gynecological ward with the AIDS-related illnesses or HIV cases like symptoms of rapid weight loss, unexplained fatigue, diarrhea, dry cough, recurring fever, or weight loss, etc. Will be, the symptoms will recommended by or cases participants recommended by the doctor who will select the participant according to our criteria, study criteria. Will be selected as a study participant. Their informed consent will be taken and their detailed form will also be filled, which deal with their previous history, including of sex relation and partner selection. Including criteria will be pregnant women with HIV. For this study, the methodology will be the blood sample will be collected and HIV test will be done in this way. We will not only detect the HIV or a particular time period, HIV cases in a particular time period, the counseling will also be done about the stigma and discrimination resulting population can also be defined by the locality because we will filling their performer and obviously they will telling us about the locality so then we can decide or we can find a key population. In case of HIV positive women, the serological test will be done after 2 or 3 months. In this way, we will follow by continuously till the deliveries and awareness session or seminars will also be conducted to stigma discrimination in the population. Next slide, please. By this study, we can expect after completion of this pilot scale study, the same methodology will also be applied on each ward of the hospital and then all hospitals of the country. So the awareness seminars to reduce stigma and discrimination. And this will be conducted in countrywide simultaneously. HIV testing of all key population will be done. So therefore, after the long study duration, at large scale on country level, the exact cases of HIV can be measured. And in this way, the
3 minutes left.
Has to be reduced. Okay, next slide. I have done almost.
Yeah.
For monitoring and evaluation is definitely an important part of any surgery. So the National AIDS Control, so we can National AIDS Control Program and ACP will be compiled. We can send the compiled data which we have done, and then monitoring desk or a monitoring cell may also be requested to an ACP, National AIDS Control Program of Pakistan, specially organized, or Ministry of Health, just only to judge the effort we have achieved for either we have achieved our goal successfully or not, and what was the missing in our action plan. So this will be to make or make your update policy or guidelines to make sure that HIV tests will be mandatory in lab panels. Being a lab personnel and a microbiologist, I will draft a research proposal with collaboration of an SAP, National AIDS Control Program of Pakistan, under the roof of my research organization, and approval of my host institute will be required. Ethical review board will be required, and then finally we will request for funding body I have already assisted. Technical assistance obviously be required to do all this, but we already have a lab set up for these techniques and also logical techniques, and so that the lab equipment may also be somehow required. So all from my side, thank you.
Thank you, Ms. Rabia. That's a good presentation from other perspective from technician from laboratories. Thank you very much. So we move to the second presentation, also from Pakistan, from Dr.Aneza. Dr.Aneza, are you there?
Yes, I'm there.
Okay, thank you. So we'll start to share your slide, and then you can start your presentation. Okay.
Thank you very much for the opportunity. I'm Dr. Aneza, and I'm a consultant physician working in the tertiary care hospital. Apart from that, I'm also a public health expert, so coordinate with ministry for similar projects. So the presentation is regarding work plan on reducing stigma and discrimination against people living with HIV and key population in Pakistan. Coming to the background, we have 0.16 million HIV cases up till the data is up till 2018, and we have 22,000 new cases each year up till the data of 2018, with only 0.05 million patients who are registered in National AIDS Control Program, which is the national program for HIV patients. So this shows that 1/3 of the population of the patients who had already been diagnosed are registered with National AIDS Control Program. That in itself shows we have compliance issues and stigma and discrimination. We have close socio-cultural environment which encourages stigmatization of key population and of people living with HIV. We have gender inequalities. The women are always blamed for HIV cases. HIV is not a priority at national or hospital level. My husband is sitting here and he is laughing at this, that I'm mentioning gender inequalities in this. The women are always blamed for HIV cases. HIV is not a priority at national or hospital level. Even in my largest tertiary care hospital, HIV is not a priority. Stigma and discrimination reduction is already there, but it is only in the books and in the plans. And practically no work seems being done in the hospitals. We have less clinical knowledge amongst healthcare workers, and thus they refuse timely healthcare to HIV patients and key population in majority of the time. Coming to the goals or objectives, next slide please. The goal is rather to say the mission is timely and patient-safe healthcare, patient-safe quality healthcare delivery to people living with HIV and key populations. And the objective in regarding the stigma and discrimination would be to prevent stigma and discrimination against HIV patients and key populations in Pakistan Institute of Medical Sciences, Islamabad. Now coming to the methods, next slide please. We would go for a 3x4 package regarding improved clinical knowledge regarding that fear of transmission of HIV among clinicians. The method would be to improve clinical knowledge of clinicians by training them, by enrolling them in training sessions, educating them, providing them continuous advisories, giving written material, and to be done, it has to be done by the Hospital Infection Control Committee in liaison with the clinical faculty who manages patients with HIV. Regarding improved awareness among healthcare workers and general population about stigma and discrimination against HIV, I think it has to be done by the Ministry of Health. The same questionnaires which are applied in Thailand may be used with certain modifications in our context, and both clinicians and population should be surveyed about what they are doing and how these vulnerable population are being stigmatized and thus discriminated and deprived of their basic human rights. It has to be done by the Ministry of Health. It has to be done by the hospital management, because we are managing patients, we are key stakeholders, and by the clinical faculty. It has to be done in support with the NGOs and community-based organization for the healthcare workers. And it can also be done for general population by arranging educational activities, seminars, conferences, medias, and surveys. Regarding attitude, I think there should be dissemination of knowledge about mode of transmission of HIV among clinicians, so that they come to know they should not be judgmental about the people living with HIV. And there should be regular advisories in conferences, meetings, and media should be used for general population. It has to be done by NGOs, community-based organizations, media personnel, and Ministry of Health. We should be very careful about non-judgmental attitudes in the healthcare. Regarding HIV-friendly and discrimination-discouraging hospital environment, I think standard operating protocols should be formed, and it has to be done by the hospital administration by non-segregating areas of HIV patients. They should only be isolated when there is a need for isolation, and regularly they should not be isolated for treatment. And no long waiting list should be there. They should not wait for appointments for long, and they should not wait for elective procedures for long in the hospital. Patients, I think this should be made a hospital policy that no testing for HIV should be done in the hospital without consent of the patients or the persons who come for it, and no verbal abuse should be done. Ensuring confidentiality of personal information of all such persons who present for testing and for further management should be the prime responsibility of the hospital management, and anyone who is violating this should be penalized for this. And very important thing is rotational duties of all staff of hospitals so that they are exposed to such patients. After this period, their fear would be reduced and they will be better managing their specialties if they come and see the patients themselves and they have first-hand experience. There should be the definition of standard hospital days for any procedure or hospital hours for medical procedures, so that it should be objective, and if there are long waiting time, it should not be done. Coming to the expected outcomes, I think there will be improved utilization of healthcare services in the HIV clinics, and thus improved registration of HIV patients which are enrolled in programs. There will be improved compliance to treatment advice, which will be shown by reduced viral load and CD4 count in such patients, and thus the percentage of those patients who have improved who have zero viral load and improved CD4 count will be high. Next slide, please. Monitoring and evaluation. There will be improved number of clinical visits at HIV. Data will be showing this thing, HIV clinical follow-up patients. There will be improved registration of new cases, which will be shown by the data. And there will be less deviation from the standard hospital hours or days for such procedures, which shows that the procedures are done timely. Motivated healthcare workers, and this should be analyzed by surveys. Utilization report of PPE supplies in HIV clinics and wards can also be used to monitor what we have done in the past. Regarding technical assistance, I think it's a teamwork and there should be a dedicated team for it. Funding is required. I think UNAID, WHO, Global Fund, they're all the international or national international agencies and national NGOs. They can always help and make a teamwork for collaboration, for technical assistance and for the financial assistance. This is all what is required. And a political commitment is the major thing which is required. If this can be applied in a tertiary care hospital, same model can be replicated in other hospitals of the country, and they can be integrated with the national action program, national action plan of the country to reduce stigma and discrimination. And one more thing I want to add, that I think there is very less work regarding stigma and discrimination being done in Pakistan before that. So sensitization of the issue should be done by the clinicians to the policymakers. Thank you very much.
Thank you, Dr. Aneza. So should we move on to Sri Lanka? Surprising, all this presentation, 3 presentations are presented by females only. This floor. Okay, welcome, Dr. Vino. Please.
Good morning. Today I am presenting the ending HIV-related stigma in health facilities in Kalutara district, Sri Lanka. According to the experience, what I learned from the Thailand Stigma Discrimination Program, this is the work plan for the project what I propose. Next slide, please. So the background information, Sri Lanka is a country of 2 billion population, which maintain low prevalence of HIV. Estimated number of PLHIV in Sri Lanka, roughly around 3,500. No key populations are the drivers of the HIV epidemic in Sri Lanka, but however, they remain below 1% HIV prevalence in Sri Lanka. So the healthcare system, mainly through the government sector, There is more than 300 hospitals island-wide under the Ministry of Health. HIV and STI services provided under the guidance of National STD AIDS Control Program, along with 42 peripheral STD clinics around the country. Next slide, please. Next slide, please. Can you hear me?
Yes.
Hello?
Yes, we
Next
can.
Yes, next slide, please. Sorry. The main goal is develop a pilot project to reduce SND towards PLHIV and KPs among healthcare providers in Kalutara district. Sorry, before that, I want to move to the previous slide. Right. Okay, next one. Right, background information. What is the stigma index situation in Sri Lanka? There are 2 qualitative studies conducted by the national program. One is in 2010, which shows the 43% of healthcare workers, the PLHIV experience the stigma in the healthcare setting. But the 2017, there was a study which shows only 2% of PLHIV experience stigma during the healthcare setting. That means the training programs have improved a lot. But there's another study conducted in 2012 among the healthcare workers. They mentioned they had stigma into 23 to 38%. So we are moving to zero discrimination along with the 95 targets. So we need to work much more. So this is the why I selected Kalutara. I am working in Kalutara. The population is more than 1,217,000 and HIV case rate is over 1 per 100,000 population. And during the COVID pandemic, I am planning to conduct, this is not the physical training program, the workshop and meeting all are in a virtual platform. So this is my goal, develop a pilot project, reduce SND, PLHIVs and KPs among healthcare providers in Kalutara district, Sri Lanka. This would be a role model for Sri Lanka. So these are my objectives. I'm thinking awareness is the matter. So I want first objective to increase awareness on SND towards PLHIV and KP populations among healthcare providers in Kalutara district and identify methods to reduce SND from there and promote free SND hospitals towards PLHIV and KP populations. These are the methods. First one is I want to identify all healthcare institutions which are providing services PLHIV and also arrange a meeting with key stakeholders, involvement of PLHIV, KP organization, NGO, CBO, government official together and develop a co-working group to work on this project. And we need to develop a separate logo. In Thailand, there is a butterfly theme, but in Sri Lanka, when people remember the butterfly, they remember reduction of stigma discrimination towards tuberculosis. It's already used. Therefore, I think we need to develop a separate logo or theme to reduce SND, and also we need to develop training curriculum and pre-test, post-test questionnaires and checklist and everything. So conduct virtual training workshop for healthcare workers. So I learned a lot of things regarding Thailand 3x facility-based S&D reduction program package. So similar to that, we need to develop like programs and we plan to conduct at the initial stage, the pilot project, the Kalutara district, several selected hospitals. So another thing is promoting the logo, what we have developed and to free SND towards PLHIV and KP. So we are developed initially the co-working group. So this co-working group will personally visit to the hospitals or the units and grant this logo based if they met the criteria. That means accreditation is doing. Conduct virtual training with all stakeholders and doing continuous improvement. Conduct refresher training if necessary. So what are my expected outcomes regarding this end of this proposal is successful
3 minutes left.
Advocacy meeting and developing working group team, development a separate logo and theme, and define agenda and course content, successful completion of all virtual training workshops, and all the hospitals in the Kalutara district will receive the hospital that free of S&D towards PLHIV and KPs. So how do I do the monitoring and evaluations in this proposal? Analyze pre-test and post-test evaluation worksheets and through the virtual training workshops, and also we are monitoring all the hospitals by hospital visits from the co-working groups, and they meet regularly and discuss what are the drawbacks in this program and modify accordingly. That means continuous improvement is there. And yesterday I noted that crisis response system in Thailand was very interesting. So similar to something we need to develop in Sri Lanka. So these are the required technical assistance and implementation for this project, because I'm not a technically competent person, so I need to find some technical assistance from the country, and also the financial support. I know that Sri Lanka is receiving grants from GFATM, so there are budget lines for stigma and discrimination reduction. So we want to discuss with GF coordinators and UNFPA and UNAIDS, and a lot of agencies are there. So yesterday we learned how to acquire the support and everything. So end of this training, I think my main target is at least something to do with the program, something like that, and do it for the people in my country. So I'm working as a consultant in Kalutara district. So there is another clinic in Kalutara. Together with my co-colleagues, I want to implement this program. Thank you very much.
Thank you, Dr. Vino, for your presentation. Okay, so before we start, can we give a big hands to all three presenters, Mrs.Rabia, Dr.Aneza, and Dr. Vino. Thank you very much for your work, your hard work. So at this moment, so it's a time for resource person to give comments, suggestion, or start with question for three countries. So can I start with Mr. Thirchai first?
Good afternoon, everyone. Can you hear me?
Yes.
Okay, thank you for the sixth group that presented. Yeah, it's very intensive work that you are working for. I am a very short question, but focusly on the community side. I think that the work that you presented is mostly implemented at the hospital or the government facility. I would like to echoing the comment from Dr. Pachara that incorporate the community into the S&D will be help you more understanding each other. And I also like the idea from the Sri Lanka that we will making the working group team that invited more stakeholders into the group and try to make it more comprehensive. I think that is another example to another country to replicate this model, especially for Thailand. I think that our Thailand is very reading country, and so we have, and in Thailand have many community that have very proactively on the stigma and discrimination. So I think that engagement the key population or the PLHIV through participation on planning workshop, or either at least create the channel to more communication is the way to more understanding each other also. And another point is that sometimes if you think about the S&D, it's not just the standalone activity. Maybe you can integrate it into the quality tools that you already have, just like the client participation or the quality improvement, and you can add some item into that. It's a very is another way to move it fast. This is for my side. Thank you.
Thank you, Khun Thirchai. So next is Dr. He raised his hand, please, Dr.
Thank you very much for the presentation for the last 3 presentations. For the comment for the first Pakistanis participants, I think it's a good start to know the HIV prevalence in pregnant women. And correct me if I'm wrong, but I listened to your presentation and you plan to, after you identify the women which HIV positive, you plan to kind of collect information about stigma and discrimination among these HIV positive pregnant women. I think maybe this is quite concerning because the mother who infected from HIV don't have time to recognize the HIV status and don't have time to experience the discrimination. So maybe not an appropriate time to discuss with them about stigma and discrimination, and maybe focus on the antiretroviral to prevent infection to the baby. That's more important. If you want to conduct survey to collect data about stigma and discrimination, maybe better to focus on the health staff and register HIV patient that you present. That's my opinion. For the second presenter from Pakistan, I am admire that you put a survey in your plan also, but I have not heard quite clearly how many surveys that you plan. For my suggestion, I would recommend that you have at least 2 surveys. The first one should be before the intervention, we call baseline survey, and the second one should be conducted maybe 3 months to 6 months after the intervention, so you can see the changes, the improvement of the practices and attitudes of the staff. So maybe plan to have at least 2. It's better to have more than that. We call long-term survey, maybe 1 or 2 years after the intervention, to see the sustainability of the intervention. For the last presentation from Sri Lanka, just to make sure that we are on the same page, because the word you use is pre-test and post-test. I think you mentioned about the baseline survey and post-intervention survey, right? If this is what you plan, is okay to me. Just to make sure. Thank you.
Okay, before we go to Dr. Pachala, for Dr. Krenka is asking question for clarification. If you friend from Pakistan or Sri Lanka would like to give more information,
that's Sri Lanka.
Sri Lanka, yes. Dr. Vino, you have anything to add on this moment?
No.
Okay, that's fine. So we move to Dr. Pachala, please.
Thank you very much for both the participants from Pakistan and also Sri Lanka. I'd like to add an introduction a bit. For Sri Lanka, we're really pleased that you're able to attend this time, because we got the request from last 2 years that, Sri Lanka team would like to come to learn on stigma discrimination in Thailand. And we said that, okay, let's waiting until the course is open. And now you're here. I really pleased and thank you for Kun Palisha to make possible, because we request to her. And also for Pakistan, actually, the community support advisor from UNAID Pakistan office plan to join, but probably she have a complete priority that unable to join us. However, I hope that we can communicate later on from Pakistan. Having said that, this time I not go to specific country, but after hearing you, I kind of able to get the big picture that these 2 countries is the, HIV epidemic is low, when compared to other countries in the region, where we learn a lot from your situation and make me thinking for country with you, with Pakistan and Sri Lanka, and learning from your presentation, I feel that what is a good thing to do, no? That's a kind of thinking back and forth on top of my head, and that I come up with the specific consideration that we can see how it fit with your context and how we go forward. And having said that, thank you very much for both countries, which you have very clear in terms of what you would like to change in healthcare setting. Very clear on both, you really highlight on what the attitude, what the practice that you would like to change over time. That's very clear. And another good thing that what I heard from both countries, everyone get into what structure country should be attached with or set up in order to move the stigma discrimination effort forward, and also apply for the hospital. That's very nice. My recommendation for your consideration. The first one is look like to me that for a country like you, when HIV is not priority. However, we should try to make the case that we would like to use HIV as an entry point, to gear toward the discrimination-free hospital, and make the very clear, very concrete pilot project to successful that we can reduce HIV-related discrimination. And then you can make it more broader that we can do for other area as well, not just HIV. Because if you file one PL-HIV in 100,000, people might not, I do what now, right? But try to make the case that using HIV, because HIV, we learn a lot from HIV, the model from HIV is comprehensive enough. And then we go that how we make the all form of discrimination free at the hospital. That's what my thinking, the first one. And the second one, many of you mentioned of e-learning in order to be like the foundation tool and also effective tool in order to increase the coverage and raise awareness, knowledge and attitude to the healthcare provider. For Pakistan and Sri Lanka might be useful to apply the India model that have been developed in Bangalore. If you like, I can connect you the team who really make that model successful, and this is the NIH project, and they prove it work very well, and I can make the connection, and you can implement quickly for e-learning. No? And the last thing, would like to echo the Dr. Grianglai. Pregnant women who infected HIV is a key and very sensitive issue, even though the country like your guy, where the very small proportion, but the disease is very sensitive. I would like to recommend that you should consult the reference on eliminate PMTCT. In that one, we have the protocol on how to address human rights issue among pregnant women. We didn't have time to go to that, but I really champion for you that you mentioned on your action plan is the right way to go, and go consult the reference, the global guide from the WHO, and you'll be successful on your implementation. Thank you very much.
Thank you, Dr. Pachala. So on my screen, there are no raised hand from the resource person yet. Are there any person who would like to add on or give comments, suggestion, advice to the three presentations? We still have time. I think Dr. Sunisa is
okay.
Okay.
Let me a little bit. I just has only one point that I think for maybe to presentation of Pakistan, just like they on the process of the start point to work on this. And for another one is I'm sorry, another one is what country?
Sri Lanka.
Yes, for Sri Lanka, it's just like they in the process of ongoing project, just like that. And just only one point for me that I think if you need to drive your team to work with you and participate to your plan, agree for your plan, should be concerned about the expected outcome that I think if I am a worker, I need to know why I should work this and what the benefit for me. If I am a caregiver, that is my view. So in your project, sometimes for expected outcome, you should convince them with the benefit that the team can got from that. That is my point, that it can motivate your team to drive and to have a power to work with you. That's it. Thank you.
Thank you, Dr. Sunisa. Yes. So I think for me, listening to all presentations, for me, I think most of you mentioned about difficulty or challenges about working in related to HIV and key population issues. So it's mean this kind of issue is kind of vulnerable. Pakistan also colleagues also mentioned about gender violence or bias or inequality in your country too. So I think if any resource persons or even though colleagues can share and discuss more about how you started or implemented the working with key population issues, such as MSM, transgender women, so it's related to their sexualities or even the sex work and for the groups of people who use drugs. So all this kind of thing are vulnerable in such a cultural sensitive context in Pakistan and Sri Lanka. So anyone would like to kind of give examples or discussion about this, how to start, how to prolong the collaboration with key populations, with women's on this kind of circumstance? I don't know.
Well, from my experience, let me share, because from my experience that I think we should start with a good relationship with them. And one factor that I think is help us too much to work, that is the key person. I mean, the key person who will be your team. And for me, I think the volunteer who came from that population, I mean, just like one guy who is the leader in our population, can be help us to go in deep with them and to let them to participate with our work. That is really nice for me.
Yes. So if you remember the story sharing from SRP program and from Jannat hospitals, story about working with people living with HIV, people who inject drugs, right? And I think Kun Third Chai also mentioned, Mr. Third Chai also mentioned about involving the key population themselves into your working group and team. But what's the challenges is how you provide a safe space for them to come and work with you. So we think about involving more partnership and into your community, into your committee or working group. So we suggest that both two countries might involve key population as a group, right? And from Dr. Vino question to Jannat, I think that time working in Islamic context, we get an idea that's involving a group of people to create a peer group involving religious leaders into a working groups, something else, something like this. What do you think about this?
For our experience, that we try to let them know that our team aware about the policy of informed consent, keep a secret, and human right. That is our strict process that we work with them, and between that time we work with them with all of that concept that we concern to youth with them. That is very significant for me.
Thank you, Dr. Sumisa. So I see the raised hand from Dr. Pachala. Yes, go ahead.
I think what the Kuniwat asking is very important, no? And we are, everyone working toward how we really make that, discrimination free for not just the PLHV alone, but PLHV who have the specific characteristic, gender and key population, etc. And this is not just specific for these two countries, but we hear from the first three as well. And I put a note the same thing. The first thing that I feel that if we would like to do that, we have to make the open channel and at all hospital and community in order to hear what their voice. We doesn't, people mention about the Sri Lanka mentioned that CRS is a one, but we should learn from different contexts, how we make the, systematic channel to get the voice from the community who are PLHV, who are key population, who are women, and that's the first step. The second step, we're talking about inclusive solution. In Thailand, when I have the committee with the global team, when we do the eliminate PMTCT in Thailand, and PLHV who infected, women who infected with HIV come and they told the team that one solution that they proposed to the hospital that we visit, that how hospitals should address the confidentiality of pregnant women when pregnant women file positive, with outside in the OPD card and etc. And this has come up from the community to propose to the hospital team. I think we should try to do more, not just a woman, but also key population, etc. In systematic way. I hope that next year we can learn from each other. Another thing, we have to understand key population more, key population who are living with HIV more. From Cambodia, we're very clear that in overall might not see the experience on stigma is very low. But I forget to ask the question that, have you ever analyzed the stigma index according to this aggregate by key population? Might be something that we should look at more together as a region to move forward. And the last thing on stigma, because we deal with the PLHV who are key population, this is a double stigma, not just the infected, but also intersectionality of the people is more than what we're thinking. And more from the study in the region, the self-stigma become the key. I think that we have to learn more and we have to think more what the innovative way to understand self-stigma. And self-stigma cannot work well if we do with the only care provider. We have to think more on innovative way how to reduce self-stigma, working with them, empower key population to cope with their self-stigma might be the answer in the future. Thank you, Khun Oniwat.
Thank you, Dr. Pachala, for additional comments. Very valuable. So are there any comments, share, or maybe from other country too? We still have time to do this. So for me to add on, if I can, so we also develop, since because we was born in what I say, heterosexual normative world. So it means we was told that we have only male and female, and they should marry, get family, having baby like that. So the stigma and discriminations are happen with other people who have different sexualities. So in terms of stigma and discrimination reduction curricula, we also develop a training session learning about other sexualities. So like, for example, among MSM, among transgender women, things like that, you can even asking it from FHI 360 or search it from Google, from other curricula, and this will be a tools that help you to learn. If you do remember the message from Dr. Supat, the director of Janat Hospital, he said that first start working with them. So if you work with them, so the key message is the same, working or learning from them. So you will understand them rather than looking at them as a clients or as a customers or as a patient, but looking at them as a friend, learn from them from different perspective, and then will become, come closely, and then you find a way to reduce the discrimination. The stigma maybe still remain, but how to practice discrimination free is a key things. The other thing is that I learned from research trial projects, when they mentioned about working with MSM in order to access to the treatment in such a very sensitive, cultural sensitive country like Uganda, that being MSM is, maybe get a kind of criminalization too. So they also create a safety net for involving these kind of people. So not just only inviting or working with peer, but they're also working with duty bearer too. Like, for example, police, who understand these kind of things, so create a kind of safety net for just a kind of emergency cases that you will get people who help, So police, religious leaders, they also come to my mind too. I think this is the kind of thing when you may think about working with them. So I don't know, other comments, other suggestions from the floor? Sorry, I didn't. Okay, so Dr. Aneza raised her hand. Please, Dr. Aneza.
I want to ask one question from the Thailand experience. In your national program for stigma and discrimination reduction, what is the role of psychiatrists and mental health experts? Do you collaborate regularly with them regarding the issues evolving in that population and their treating groups?
Yes. Oh. What is the role of psychiatrists? I think Dr. Sunisa made smiling. She's her professional is on that. But well, the question from Dr. Aneza is about in Thailand authority bodies. Do you always consult with the psychiatrists? Was it their role? And anyone from the authority first, and then maybe Dr. Sunisa can add more.
This point is just like the guideline in the service system. I mean, the guideline in the service system will be have the channel that if the healthcare provider who work with this population for some cases have the mental or psychiatric problem, they will have the channel to consult to the team of psychiatry in that service. And I think one part that they have just like the project to gain the knowledge and skill of our team to have the just like the instrument to first assessment for the population who will in the list of this problem. And then after that, if such as they have just like a depression scale to assess for the population, and then if they got the positive scale, they will consult to the psychiatry to take care of this population. That is the guideline that they got in for me, for my experience, in every healthcare setting they have this one. That is.
Yes. What I learned when I visit the hospital, mostly the psychiatrists are working with youth, people who inject drugs. So people who work in the ART clinics also consult them and involving them into this group too. So in practical way, but I don't know in the national guideline what does it say in that. So anyone can anyone add in, or we can find it later?
I did 3 studies in Pakistan on transgender population. And in that, I found out that anxiety, depression, and suicidal tendencies are quite high. As we learned right from the beginning in the surveys that situational analysis is very important. So a lot of subjects were covered. I think in your stigma surveys, stigma index surveys, content from that assessment should also be included so that you come to know of situational analysis rather than when the patients present and what is the burden of disease. To know the burden of disease, I think the psychiatrist should be part of the policy making also.
Thank you. Okay, if there is no one at this moment, I think we have time and we need to move on to the third groups. But before we move on to that, can we give a big hand to all presenters again? Thank you for Rabia, Aneza, and Vino. Thank you very much. Okay, so okay, we move to the last group. So we have 3 presentations. I think we just finished all 3 females, and maybe we move to all 3 males. I guess I'm not sure, but well, this next session will start from Tanzania, Dr.Albert, and then Timor-Leste, Dr. Mark, and then Myanmar. I don't know whom will be presenter. So can we start with Dr. Albert from Tanzania first?
Yes, Niwat.
Thank you.
Okay, good morning, everyone. It is in the morning here in Tanzania. So let me share my slides. So can you see the slides?
Yes, please shoot it to big screen. Okay, that's clear.
Okay, thank you. So my work plan on my proposed project will be on the 8th facility of stigma and discrimination related to HIV. And coming to the background or problem statement, so it is estimated that from the data on Tanzania Commission for AIDS, this is official governmental organization that deals with HIV/AIDS. So it is estimated that around 1.4 million people are infected with HIV in the country, with a prevalence of 4.5%. So that is a bit high. And coming to the previous targets of 90, Tanzania made a good progress relatively, in which by 60.6% of people living with HIV were aware of their status, and 93.6% of them they started on ART, and 87.0% they had a suppressed viral load. So there is efforts on Tanzania government that on prevention, treatment, including the adoption of the treat all patient, regardless of the CD4 counts or WHO classification. So despite the all the strategies that include also the good investments on research and publication, still the country lacks some of the data on the magnitude of HIV, on stigma and discrimination, especially in the Kigoma region, which is western part of the Tanzania. And according to Stigma Index report, 25% of females and 40% of males in Tanzania, they fear to interact or work together with people living with HIV. And the strategic outcome for this, from this report was to reduce this stigma from 40% to 0% by 2022. And as I said, currently there is no data on magnitude of HIV related to stigma and discrimination in western part of the country. The most available data are qualitative one that show the existence of stigma and discrimination with its manifestations. So for example, in this study of which was done by Muhode and Nyamhanga in 2016, it showed the different existence of different forms of HIV-related stigma in Tanzania, which are verbal, social, perceived stigma, with various forms of discriminations, as relational discrimination, mistreatment of healthcare workers, blame, and rejection by spouses. So my goal will be to end HIV-related stigma and discrimination in the region, so as to fast track 95 targets, with the objective, with two objectives. One being develop S&D measurement tool and use it to measure the HIV-related stigma and discrimination in health facilities of Kigoma district. And again, to adopt the wonderful model, wonderful 3x4 package that we have learned from Thailand in the health facilities of western part of Tanzania. So coming to methodology now, this project will, as I said, will be conducted in Kigoma Urban, which is one of the 8 districts located in western part of Tanzania. This region actually is in the border. That is, there is interaction of people from almost 4 countries, Congo, DRC, Rwanda, Burundi, and Tanzania. So in the region which is located in the border. So the district has a population of around 215,458, which is projected from the census that was done in 2012. With this district, of course, comprises of 2 hospitals, 3 health centers, and 18 dispensaries. And the health facilities that provide the HIV services are 9 within the district. And of course, I'm proposing to involve all 9 health facilities in my project. So this project is expected to be implemented in 2 phases. The first phase will be on measuring the HIV-related stigma and discrimination in the 9 health facilities of Kigoma district. And I'll use a adopted quantitative survey that we are taught and discussed on it. The phase 2, after knowing the magnitude of the real magnitude of the problem, then I will apply a 3x4 reduction package model to the region.
3 minutes left.
Okay, thank you. Which will include conducting training on stigma and discrimination, to try to change the negative attitude, which is one of the key drivers on stigma and discrimination, increasing awareness on HIV transmission and preventive measures to avoid unnecessary fear, to sensitize the good environment to the hospital for the patients to attend, and also to involve the community and listen their voices by organizing meetings in the village or streets in collaboration with local leaders. So the expected outcome is to know the magnitude, as I said. I think in 2 months will be enough to know the magnitude and to end the stigma and discrimination. Monitoring and evaluation, this is a logical framework of each, whereby I will be having an impulse like human resources, the fund, the village and the strictly local leaders, activities which will be to quantitatively survey on stigma discrimination, training, doing medical campaigns, outputs, outcomes as performance indicators, which will be getting the baseline findings on the S&D, increase the facility utilization, and increase the healthcare workers' knowledge. Of course, with outcomes of health facility free of stigma discrimination and a reduction of dropout patients from HIV clinics, with the big impacts of fewer deaths related to HIV. Of course, I will be doing also supportive supervision periodically, and they're doing the survey at the end of the project. So the required technical assistant, first will be on the technical aspect, which I will request for the tool, to adopt the tool for quantitative survey and learning more on 3x4 reduction package. Okay, the financial support that will be asked from phase 1 of measuring HIV-related stigma, the magnitude of HIV-related stigma and discrimination in western part of the country, and financial support on phase 2 to apply the 3x4 reduction package to fast track 95 targets. So thank you very much for your time.
Thank you, Dr. Albert, for your in-time presentations. So apologies for all that I missed counting, make mistake on time management. So I stole your time for a while. So well, let's see how can we manage this. So let's move on to the next presentation from Timor-Leste, Dr. Mark. Dr. Mark, are you there?
Yeah.
Okay.
I'm here.
Will be challenged. You have lots of details information, but you have 9 minutes equal as other people.
Okay,
So,
I will try.
Okay.
I will try to share this one. Can you see my slide?
Yes. And you should it go to big screen? Yes, please.
Okay. Okay. Actually, I'm a little bit different here. I joined with my friend Dr.Aneza. I try to do all. Only a few days I got health issues. Okay, here is my outline, and this is my country profile. So maybe some because Timor is not unknown like other country. It's like a very young country, so many people do not know about us, and then that's why I always put this people and culture, like identity. Actually, that guy is my great grandpa. Okay, this is laws related to freedom of citizenship. There are Article 30 and Article 28 is talk about the freedom of being people, and then I put here Article 57 in the Timor-Leste Timor-Leste Constitution, because in Article 57 it says that health is free charge for everyone, so everyone not need to pay if go to hospital or inpatient for treatment for all. And then this commitment for the government is end this HIV in 2030 by decentralize all of the service, and then fortify the primary health care, and support from all partners can be strengthened and more. Yes, Timor-Leste HIV situation since our independence 2002 until 2013. The first the case until now we resist is 1,374, and then the big barriers. Why I focus here in the stigma, because when the stigma high, the one of the problem is also the test, the diagnose for the patient also low, because they will not come to our health facilities.
Yeah, this is the worldwide living with HIV, and then Timor-Leste is included in the less than 10,000. Actually, this is a total case, like I say, 1,374 with prevalence rate 0.02. It's one of the very low, but indeed it still increase. And then the most affected here is age, productive, a young age. And then also the pregnant mother also get, some of them get the infected, but it's still very low. I put here some of the district distribution here. Actually, yeah, this is what I tried to design this plan. The objective here is to identify 90% of the estimated people living with HIV. Lincoln identified HIV positive to care and provide ART, retain people living with HIV on ART to have sustained viral suppression, reduce new infection among key and vulnerable population. And by those, we also try to reduce the stigma and discrimination, not just in health facility, but in the community level also. I don't have much time. Okay, there are those are the core indicators that I already mentioned before. Yes, what I want to do, medical cooperation strategy, the analysis, the problem. The first is that we Timor still have many problems: economically, security, politically, the stability, many infectious, contagious, non-contagious disease. Even stigma, discrimination rate in Timor is still high. Actually, in Timor, very few research being conducted yet about stigma and discrimination. But in 2017, there are one research to be conducted. And then they choose from this research, they choose 81%, 39 women, 38 male, and 4 transgender. And from this result, it showed that more than 50% still experience stigma and discrimination. Some even excluded from the family activities. It's like this guy, Elton John said. There are no difference between HIV and diabetes, only the stigma. And this is a stakeholder that I did, GO, NGO, and others. I hope also in here we can be a partner to help each other, and including also other like universities and researchers and communities. Yes, I did some SWOT analysis for this project. I hope it can be implemented very soon. Yeah, this is the strength, the weakness, and the strength, like health system. One of the very good strength in Timor is the free health care for everyone. No one needs to pay. And then the presence of health professionals is mostly in the old village, and good accessibility. People can access for healthcare. And then after we have we already start electronic registration. That's why I really want to learn I hope in the future with Timor we can have like a HIV line service for like a pokpun. I hope we can have our own like pokpun. And the weakness here, I'm sorry, still feed a lack of medical equipment, and some remote area geographical condition is still not good. And the society, many still consider HIV as a curse, and then the HIV stigma also is still high. And then other cultural, educational, and I think those issues is very important to be solved. And the opportunity here is okay, I will try to do it. And this is opportunity and threats. Implementation of strategies. We establish a partnership, and then find the problem, and then solve together here. Actually, I have here some detailed plan. I already put the number here. I hope very soon Thai and Thai CDC can do realize that. This is what I want to do is HIV DOT training, HIV SDN training for all of health professionals in all of our ART center, like one national hospital, 5 referral hospital, and then even until the private sector that hold the ARC centers, and until all of personnel can, and this project is one first year and then continue by the second year, and the third year I want to increase health promotion and increase more participation the community level. Like first and second year is for the health professionals, and the third year more focus on the community level, and then monitoring and evaluation plan, and then we must create like a periodic review, regular community monitoring, and then yeah, thank you. Actually, it's so many I cannot read one by one. Yes, that's my reference.
Well, okay, thank you very much. You have lots of slides, but because of limited of time, I'm sorry for that too. But anyway, I think that we can share the slides to other countries too, at least for learning and studying in detail, right? Okay, so let's move to the last country from Myanmar. I don't know who will do the presentations.
Oh, I would like to present.
Okay, thank you. Will you share your slide by your own self or?
Yep. Yes, sir. Let me share. Hello, everyone. I'm Dr. Sindhu, and I am a postgraduate public health student from Myanmar. I would like to present one action plan on HIV prevention and reduction of stigma and discrimination from Myanmar. Firstly, introduction or background information. HIV is one of public health issues in Myanmar. The first case of HIV in Myanmar was detected in 1988. Myanmar health system is released to means of public and private system. Ministry of Health is major provider for comprehensive healthcare. Regulation, Myanmar Medical Council law, coordination, Myanmar Medical Association. National Health Policy of the Ministry of Health and Sports placed health for all as primary aims and presents a roadmap to achieve universal health coverage. In May 2017, Myanmar launched National Strategic Plan for HIV and AIDS 2016 to 2020. The National Strategic Plan is in line with UNAIDS global strategy of the first threat to act AIDS, with the aims of ending HIV as a public health threat in Myanmar by 2030. The strategy of HIV National Strategy Plan 3 will support the government efforts to redress health inequity, improve quality, efficiency, accountability, inclusion, and accessibility. This 2014 census put the population of Myanmar at more than 51 million, of which two-thirds all living outside urban area. HIV prevalence in Myanmar is estimated to be 0.57% of arrest population in 2017. Until it was estimated that there were 227,000 living with HIV. And this HIV prevalence among key populations in Myanmar, people who ingest drug and 34.9%, females sex worker 45.6%, males who service maid 11.6%, adult male 77%, adult female 0.39%. According to the epidemic modeling, there were estimated 11,000 use infection in 2050, approximately 3 infection per day. And the rest of Myanmar states integrated various surveys and HIV surveys data. In Yangon, in 2014, Yangon 29% friendly, 60% and 30%, 30%, 80%. Others are the goal and objectives Myanmar's National Strategic Plan on HIV and AIDS 2016 and 20 was efficiency to HIV as the public health threat in Myanmar through fast-tracking access to convenient, integrated, and highly quality service that protects and promotes human rights for all. Overall goal strategy is to reduce HIV transmission and HIV-related morbidity, mortality, disability, social and economic impact. To achieve this goal, there's are three objectives. Objective one is reduce incidence among priorities, population, and their partner. Objective two, facilitate actual violence suppression for all people HIV. Objective three, improves the everyday environment to support the response. This prevention, HIV prevention can treatment and more, and this to reduce the stigma, discrimination, violence, human rights, Buddhist law, zero tolerance for stigma. And this identify race and text and rectangles people living with HIV in care and disease and sustain ART suppressed violence. And there's 5 strategies traction. There's number 1, reducing new HIV infections. Number 2, improving health outcomes for all health people living with HIV. Number 3, strengthening integration of community and health system, promoting a human rights-based approach. Number 4, strategies, strengthening strategic information research to guide surveillance, delivery, management, and policy. Promoting accountable leadership for the delivery of the research and financing sustainable response.
3 minutes left.
Okay, sir. To methods to achieve the objective geographic distribution on needs and risk, HIV infection, local programmatic mapping and prioritization, such as HIV service package, HIV prevention, integrated HIV testing, and counseling service, HIV clinical care and ART, including PMTCT, safe blood supply, and enabling improvement, service delivery more risk, and strategic directions. Step 1, reducing new HIV infections, increase key combination prevention intervention for priority populations, maximize HIV testing, minimize efficiency in service delivery, work toward the elimination of mother-to-child transmission of HIV. Research. These research as follows. Strategies tries into improving health outcome for all people living with HIV, maximize administered enrollment, linkage retention, improve quality, efficiency, coverage, care, and ART, negotiate TB and HIV, monitor bias suppression, and positive prevention. He research 90% of diagnosed people living with HIV receiving ARTs. 90% of adult and child ART development applied decision of ART. Strategic strategy 3, strengthening integration of community and health system and promoting a human rights-based approach. Strengthen optimize efficient HIV service delivery, invest in big robust system for health, strengthen community against exclusive delivery, reducing stigma and discrimination. Key words as follows. Strategy try to first.
1 minute left.
Okay, sir. Strategy strengthening strategic information and research to guide service delivery and manage policy. Key words as follows. Strategies try to emphasize promoting accountable leadership for the delivery of research by all partner and final their response. Key words as follows. Monitoring implementation, planning and implementation, human resource, infrastructure, structure will promote HIV service, provision of HIV prevention care, treatment service for the key population, HIV prevention, information and education, HIV testing service, HIV care and treatment laboratory service, information of people living with HIV coordination and partnerships. Oh, thank you for your kind attention.
Thank you very much, Sintumen. Thank you for your presentations. Okay, so since I make mistake on time management, so I think I'm so sorry about that, but we still, if we still have a room like for 1 or 2 minutes for resource person to give advice or suggestion to all 3 presentations. Are there any things from our resource persons? I'm so sorry about that. Yes, yes.
Kuniwat, I can do a quick comments.
Okay, thank you, Kuntananda.
Thank you for all 3 last presenters. That's very exciting to see your draft plan within short timelines. And I can see your eagerness in doing the S&D program in your country. So I think that's the great start, that you have the energy from learning from this course and try to develop your S&D program. I think for Tanzania and Timor-Leste, you have quite a comprehensive plan already, and I feel exciting that you get a lot of contents that you learn from this course and adapt into your plans. And it sounds very promising, but it's also very ambitious plan as well. So maybe general comment is that you can start from small, but the whole plan, you can keep it like that. But you can start from just little by little if you still don't have big team or big funding yet. But I know that at least in Tanzania and Timor-Leste, we have, even in Myanmar, we have PEPFAR program, and I understand that you have Global Fund program over there too. And in Myanmar, I think we have both CDC and USAID funded through PEPFAR programs, and both have the stigma discrimination activities. Tanzania as well, I think Tanzania has big budget from PEPFAR, not sure for Global Fund, but you may need to seek where the main implementing partners of PEPFAR that you may, I understand that you are in the Ministry of Health, right? I think your colleagues might have some activity of project collaborate with PEPFAR. So you may propose this piece, the stigma discrimination piece, to tie to the main proposals. Timor as well, I think Timor-Leste, oh no, so that's Papua New Guinea. I'm not sure for Timor-Leste. You may have Global Fund, right? But not sure for PEPFAR. So that could be source of funding, or UNAIDS office could be a great resource that you can start with, where to find the partners. You may put the program in more concise, put the background, the data to support, and you can put in the plan that you learn from the course. And the crisis response stuff may be good things to start, particularly for the country where have small number of HIV people. Because if you do a big intervention, but you have few people, few HIV people, it's more like you start with a big things. But as Dr. Patra mentioned, you might use HIV as one of the elimination of stigma discrimination for other group of people as well, not just focus only HIV. But Tanzania may be different story because you have larger populations like that. So I guess maybe that's my quick comments. I think actually I have more, but sorry, I know that we have a tight timeline, so just a quick things. If you have more question, you can follow up through the ITC or to any speakers or UNAIDS. I think you may have additional resources. Thank you.
Thank you for your quick comments. Okay, I'm really sorry that we run out of time. It's my mistake again, sorry. So I think before we take a break, can you give a big hand to all 3 presentations and Kuntananda too? Thank you. So can we take a quick break for like 5 minutes and we'll come back for the closing ceremony. Thank you very much for your attention.
Try to finish on 1 p.m. So before that, before the closing ceremony, so our team would like to show a video. Please see with your heart. So please start the video. I think you can feed from this video. This video actually is telling that the patient care is more than just healing. So it's like building a connection that encompasses mind, the body, and the soul. So you will see the message that you could stand in someone else's shoe, hear what they hear, see what they see, and feed what they feed. So would you treat them differently? That would be very encouraging message for the reduction of stigma and discrimination. And also you can treat the patient with sympathy. So I think after this section, so I would like to move to our formal closing ceremony. So before that, I would like to invite our next MC, P. Diamond, to take the floor.
All participants, ladies and gentlemen, we reach the end of the online international training course on ending HIV-related stigma in health facilities to fast-track 95 targets for 7 days. We are now ready for the closing ceremony. We will start with Ms. Parisha Chanchalat, the Chief of the International Collaboration and Training Session, Division of AIDS and STI, to give the closing report. And then Dr. Shivanan Lerpiliyasawat, Director, Division of AIDS and STI, the representative of Director General, Department of Disease Control, to give the closing remarks. Now, may I invite Ms. Parisha Chanchalat, the Chief of the International Collaboration and Training Session, Division of AIDS and STI, to give the closing report. Please welcome Ms. Parisha.
Dr. Shivanan Lerpiliyasawat, Director, Division of AIDS and STI. I would like to say thank you for your presiding over the closing of the International Virtual Training course on ending HIV-related stigma in health facility to fast-track 95 targets. On behalf of the training, organizing, and support team, I would like to report the result of the training and evaluation as follows. First, there are 22 participants who have attended this online training course. These participants are from 10 countries: Cambodia, Iran, Laos, Mauritania, Myanmar, Pakistan, Sri Lanka, Tanzania, Timor-Leste, and Thailand, who engaged in the online training course. Second, from the result of the evaluation lastly, it showed that the objective of this training was achieved. Most participants agree and strongly agree that they better understand stigma and discrimination issues and more confident that stigma and discrimination reduction strategies are possible and measurable. Also, the thing that they like most are experienced facilitator with time punctuality, good interaction session, organized module, the kindness of organizers. Also, all lecturer and facilitator are kind, warm, and sweet, as well as have various speakers to share knowledge and exchange experience. While the thing that they dislike most are long and busy slide presentation, internet connection, type of training virtually. The training period is too short, especially during the participant sharing experience. As for the action plan, 9 countries have presented action plan to reduce stigma and discrimination in healthcare facilities. However, some participants pointed that the obstacle to implementation after training, such as COVID-19, budget support, limited resource, and not being a policymaker to do the program in large scale. Also, some participants mentioned the need for ongoing technical support from the lecturer and experts. That's all some result of assessment. And I would like to sincerely thank all respondents for taking the time to complete the survey, and to all participants, speakers, and facilitators who were with us during the 3 weeks of this training. Finally, I'm delighted to say that the performance of each individual was satisfactory by criteria for the course completion, and certificate will be given to the participants who have more than 80% attendance. Therefore, TICA will send the e-certificate of attendance to the participant by email after this. Now, it is a great honor to invite Dr. Shivanan Lekriya Suwat, Director Division of AIDS and STI, to deliver the closing remark. Thank you.
Distinguished participants, ladies and gentlemen, it gives me great pleasure to preside over the closing of the International Virtual Training course on ending HIV-related stigma in health facility to fast-track 95 targets. I would like to extend my congratulations to all the distinguished participants who have successfully completed the online training course, and I hope that you will gain the additional knowledge and experiences from our speakers, facilitators, and our team members from the Division of AIDS and STI, Department of Disease Control, Thailand. I also assume that all of you have actively participated in classroom lectures, discussion, sharing experiences, which are highly important and related to the training course. At the time when our resources are getting more limited, we need to deliver the comprehensive arrangement to achieve a goal of cost effectiveness in every way we can. I hope that you could do your best to be able to apply what you learn from this training to overcome most of the challenges and continue to seek updated knowledge and sharpen your skills to improve the quality of your work. I do hope that your ascertainment in this course would enhance and strengthen your existing knowledge and skills, which will be useful and relevant to improve the performance of your responsible works. It will be even more worthwhile and commendable if you contribute the knowledge and experience from this course to your colleagues in your healthcare settings. Moreover, I would like to encourage all our participants to start any activities or introduce some projects regarding the reduction of stigma and discrimination of PL-HIV and key populations by applying some methods and initiatives that you have learned for this training to reflect cultural context of your country. If you need further technical support for your implementation, please let us know by sending us the email. Also, you can share your success stories in the next training session if we have a chance to organize in person next year in Thailand. Finally, I would like to take this opportunity to express our sincere thanks again to TICA and Thailand MOPH US CDC collaboration for financial support to this training. I also fully thank Dr. Tuvisap Siraprapasili, our course director, and Mr. Niwat Suwanpatana, expert on stigma and discrimination, our course facilitator, for making this training course possible. My appreciation also goes to the resource persons for their technical support. Also, the indispensable things to mention here is that the participation of the participants in this training had ensured the successful training of the objectives. Our feedback received from your responses through the questionnaire will be used to improve the next training session. Once again, congratulations to you all, and I hope that our participants will have safe and good luck. It's now my pleasure to announce that the International Virtual Training course on ending HIV-related stigma in health facility to fast-track 95 targets is successfully finished. Thank you.
On behalf of the organizer, we would like to thank Dr. Shivanan Lerthiliyaswat, Ms. Parisha Chanchalat, and the resource persons. And we also would like to thank our distinguished participants who are here for the attendance of the online training course to sharing your experience and knowledge. For the certificates of attendance, TIGA will kindly send the e-certificates to participants by email. And I remind you to do online questionnaires by email in order to evaluate the online training course. And we hope that the next year or after the end of COVID-19 epidemic, we will arrange the additional course to see and learn from the actual implementing activities in Hat Yai Hospital and Jana Hospital in Songkhla Province. And we would like to invite you to apply this additional course. TIGA will announce the application again. And finally, thank you and goodbye and have a nice holidays.